So in this lecture, we're just really going to cover managing foreign bodies and rust rings. So when we think about corneal foreign bodies, they are the second most common form of ocular trauma, with an incidence of 8 per 1,000. They comprise about 30% of ocular injuries. We know that most cases present with generally a very clear history. Sometimes there's no history other than maybe just a little bit of recent irritation. Before we look to remove anything from the cornea, the first thing to do is to check their vision and pupils. Check that they haven't got any relevant history like LASIK or keratoplasty, as this may interfere with the flap and cause a more aggressive issue. Ensure there aren't any secondary ocular surface foreign bodies, so if you've removed one, check there isn't more than one. We don't want any signs of retained intraocular foreign body. Have a look at the anterior segment for cells and flare. Have a good look at the depth if you can with a nice cross section. And occasionally this is it benefits from actually rotating the illumination and viewing columns to the side so you can get even more of a cross-sectional view. If you do suspect the possibility of a penetrating injury, do make sure you dilate and review the fundus just to check how far it's potentially gone back. In terms of the most likely scenarios, typically it's things like grinding injuries or hammering, branches from trees, that sort of thing. But when the foreign body itself is from grinding, that is a hot spark that welds itself to the cornea, and classically they tend to present with a delay, so usually 24 to 48 hours after the episode itself. Hammering, the fragments tend to be sharp, and so they are more likely to penetrate the cornea. It's an important test for perforation, is the Seidel test, where you put in a 2% fluorescein from a minimum and see if you get any sign that fluorescein is diluted by any fluid leaking out of the eye. Another good check for perforation is to look at the pupil. If the pupil is regular, then that you're less likely to have a perforation. But if you do see a warped pupil like this one here, then the direction of the warped pupil often points towards the direction of penetration injury. The types of material that we tend to encounter most in practice are metallic, could be glass, stone, organic material, or indeed nothing at all. Sometimes you end up with suspected foreign bodies which are actually not foreign bodies at all, but matter actually from the eye, so maybe an eyelash or a concretion in the eyelid, cap meibomian glands, or filamentary keratitis, or an inclusion cyst buried in under the lid. Corneal abrasions, obviously you can get the injury without any retained foreign body. The injuries are usually pretty obvious, so it's either a flicked branch from a tree or it's a fingernail from a child, but obviously it no longer is resident on the ocular surface. They are quite painful, and vision can often be a bit compromised. The wound healing of these requires epithelial cells to migrate and proliferate into the wound site, the corneal epithelium has 3 layers, and that is the basal layer, the one that's capable of regeneration in the wound healing process of these sorts of abrasions. Always worth giving the patient a course of lubricating drops and often ointment at bedtime as well, just to help in the healing so you don't get any recurrent corneal erosion issues moving forward. This slide here and this video is an example of a corneal foreign body. So you can see the foreign body at about 5 o'clock on the cornea there. There's a metallic foreign body. So we've put the local anaesthetic fluorescein combination into the eye, and then you can see how the region is glowing under the fluorescent light as well, really just to highlight the area. In terms of then managing that problem, what we've done in the video here, you can see, is just got the needle a 23 gauge needle here, and then just lifting, ideally if you can with the sort of side of the needle there, lifting the foreign body out of the way. It's not always easy to get them to attach to the needle itself, so sometimes you end up sort of playing about with them a bit, and then as per here, quite often they then blink and the foreign body is left in the lower tear prism, and usually retrieval of that can be either with a cotton bud, usually what I reach for, or if you need it, a pair of jeweler's forceps. This video here, you can see the aftermath of having removed that foreign body. There's no residual rust in the cornea. And in this case, just a few infiltrates. That's why the cornea is still a little white, but that should settle over time. Maybe scar if it's deep enough and goes down into the stroma, or not if it's just superficial. So AlgaBrush, in terms of clinical practical use, they are a rotating burr which we use in clinic to remove the rust-ring from the cornea. There's a small risk of a chemical sepsis if the rust-ring is actually left within the cornea, so if you do see significant amount of rust, it is important to try and get it out. You use the actual AlgaBrush parallel to the cornea and basically just touch it to the surface of the rust ring to debride it and take it away. And you do keep doing it until the rust ring has gone. And then afterwards you may want to irrigate and maybe use a cotton bud just to remove any residual little bits that are floating around. This is the head of an AlgaBrush here that you can see compared to the needle, but the little burr at the top spins just to help debride the rust ring itself. So rust rings are very common. Once a metallic foreign body has been in the eye for anything from 4 to 6 hours, the adjacent tissues actually start to rust in that short time. So you get sort of brown tissue which feathers into the border of the corneal wound. This itself can promote inflammation in the surrounding tissue, which is often seen as infiltrates in the corneal stroma. And that can lead to the development of things like bullous keratopathy, stromal edema, and angiogenesis, promotion of blood vessels. So this little video here is an AlgaBrush. So the actual original foreign body has been removed, and then the AlgaBrush is just being applied to debride the rust ring from the wound site. After the event, it's really important after you've removed foreign bodies to make sure that you consider what the wound healing is going to be like and what the patient needs moving forward. If the foreign body has any risk of infection, so it's maybe organic material, or the wound site is large, then you'd want to use a prophylactic antibiotic such as chloramphenicol 4 times a day for 5 days. If it's larger, then sometimes cycloplegia helps just to prevent pupil spasm and keep the patient more comfortable. With contact lens wearers, the prophylactic cover should be used with a drug that's effective against gram-negative, so something like a quinolone, like levofloxacin or mofloxacin, and these obviously, if you're needing to, you can request a prescription from the patient's GP for that. Systemic analgesia, so typical course of paracetamol or ibuprofen if the patient's in discomfort, and sometimes you can use also a topical NSAID if required for a few days after the event. Hopefully that's been a useful summary of dealing with foreign bodies and rust rings in practice.